Segue for me to introduce Dr. Trudy Larson, the professor and founding dean of the School of Community Health Sciences at UNR, leading a school dedicated to public health and improving community health, extends her passion for improving health for all. And that's what I was just talking about at the beginning of our meeting today. It was part of our mission to create and support healthy communities. And that's what Dr. Larson has been doing for 35 years. Her primary area of interest had been HIV/AIDS immunizations. She spent 35 years caring for people with HIV/AIDS, advocating on their behalf, and she continues her role as medical director for Washoe County Health Department Immunization Program. Prior to this appointment, she was professor in the Department of Pediatrics and former chair and associate dean at the University of Nevada, Reno School of Medicine. Dr. Larson is past chair of Nevada Donor Network Board, oversees organ and tissue donor programs at the UNR School of Medicine, is a board member at Northern Nevada HOPES, active on the Nevada Public Health Foundation Board, and currently serves on the governor's medical advisory team for COVID-19. Dr. Larson received her medical degree from the University of California, Irvine. She completed pediatric residency, University of California, Davis Medical Center, followed by a fellowship in pediatric infectious disease at UCLA. And she's been at the University of Nevada, Reno since 1984. And I understand she just retired. And so I deeply appreciate that she was willing to be with us today, just for us to tell us some of the things she's heard. You remember, I started out our meeting today, and Dr. Larson was not yet on, talking about a different kind of virus that's really ignorance, that spreads because it spreads misinformation, which even mutates to hatred. So this misinformation is easily dispelled. And Dr. Larson will give us some of that verbiage that you can respond to the community, maybe to your loved ones, to people you know, so that they will understand the facts and truth. So Dr. Larson, welcome. Are you there?
I am here, and I have an annoying noise outside, but hopefully that won't get in the way. So what I wanted to do today really is maybe do a little intro, and then I'd love to open it up to question and answers. In case some of you are shy, I actually have a whole list of questions I've been asked over the last year and a half. So I always have a share of things that I've really investigated, because I think the questions are good. Everybody deserves an answer. And it may not be the answer they're looking for, but everybody deserves an answer. And they deserve the time to talk about fears and concerns. And so that's one of the really major talking points that I tell budding physicians, is that when we have a situation like that, which is a first in a lifetime, I mean, I was part of the HIV/AIDS pandemic back in the 80s, but that was a very slow moving and very specific kind of pandemic. The one we have now is respiratory spread, which means it's fast. And just to put it into perspective, this virus, which a coronavirus is an RNA virus, it's subject to mutation, a lot of mutation. And the problem, obviously, is that this time when it mutated, it was sufficient enough so that it was new to every single person in the world. So the entire world was susceptible to this new virus. And that's the way nature works. This is a natural phenomenon. It happens with influenza. We know a lot about influenza. Coronaviruses tend to do this more sporadically. There was SARS, there's MERS, those are all different coronaviruses. But this one was sufficiently different that nobody had immunity. And so it ran rapidly because it spread through the air. And I think that transmission piece is really critical to understand. This is about breathing in and out virus particles. And so it makes perfect sense the closer you are to somebody, if you're infected and you're not wearing a mask and they're uninfected and they're not wearing a mask, then within 6 feet, these particles can transmit to the other person who can breathe them in, because that's how you get infected. You breathe it in, and it will, because there is no previous immunity to it, it really goes very rapidly into the lungs, a respiratory tract for some people. And for others, it may just be more like a cold. So part of the problem here is we have some predictability about who's going to get really sick. We know those who are older, who have less immune reserve, are going to get sicker. Anybody with underlying health conditions that really impairs their ability to respond to infections is going to have a worse outcome. But other than that, there really is no way to predict who is going to get a really bad case of this SARS-CoV-2 coronavirus, because it appears that it may have something to do with how much virus you inhale. It definitely has to do if you get the Delta variant, and Amber did a very good job of explaining that. So it really has to do with this Delta variant, which is 2.5 times more transmissible than the strain that came into effect almost a year and a half ago, and it results in higher viral loads. So the transmissibility is a lot easier with this virus. And so you can think about people breathing the same air, and that's the issue. When you breathe the same air and you're close enough, that's an exposure. So masks have been used for, actually, I don't know how long, probably centuries in many parts of the world to try to prevent those respiratory particles from getting in, whether it's respiratory carried, whether it's air that carries smoke or other things or viruses. Masks have been very effective forever, and they're still very effective, and they're one of the few things we know will make a big impact about people either breathing out or breathing in these virus particles. And so that has been shown over and over and over again in a multitude of scientific situations to hold true. Even for, some of the flimsier masks, it still reduces what goes out and what comes in. So we have masks, and that's really good, but that's not sufficient in many cases, because people who get sick oftentimes have no symptoms for at least 2 or 3 days before they're infectious. And so they may not be careful enough with mask wearing, for example, and then that transmits. So masks are one line, but because we cannot predict with certainty who's going to get the bad case of COVID, it really begs the question of what can we do to prevent infection and disease in the first place. So I'm going to digress really briefly and talk about what vaccines are supposed to do. So there are 2 things that vaccines are supposed to do. One is, of course, they stimulate our immunity and we make antibodies, and that protects us. But there are 2 outcomes that are desired. The best is if it prevents infection. Can that immunity that is derived from the vaccine prevent infection? That's hugely uncommon with any vaccine that we've ever had. Measles is probably the best example of that. And periodically, even that, there will be breakthroughs, but very, very few breakthroughs with that one in terms of actually getting infected. Almost all the rest of the vaccines reduce disease. So when you get infected, if you get infected, you don't get sick. You don't get seriously ill, you don't go to the hospital, et cetera. So those are the 2 outcomes we desire. So the fact that our COVID-19 vaccine that we currently have doesn't necessarily stop infection is not new news. That's sort of what we see with vaccines. However, we know now, even with the Delta variant, these vaccines protect from getting seriously ill and going to the hospital. But they do not protect against getting an infection. They're still doing the studies because remember, this is a new virus and we learn as we go. That's what's so uncomfortable for those of us in medicine. We like to know, but we don't know. And so we have to follow and read and do the statistics and everything else so that we learn on the go, which is exactly what we're doing. So we want to know, will the vaccine reduce the amount of virus that's in your respiratory secretions? We're not quite sure of that. It certainly did it with the first strain of COVID. But with the Delta variant, that's what they're looking at right now. So until we know that, then we need to be careful. So right now, the best line of protection for a person and for those around them is the vaccine and indoor masking. It's been shown very clearly that outdoor masking really doesn't add much at all. I would modify that for people who are immune compromised because they tend not to have such a robust response to the vaccine. They don't get all the antibodies and responses we'd like. So they need to be more careful even outside. But outside, really, the risk of transmission because of air currents get interrupted. And especially if you, and most of us do not like people like this close to us. We don't like that. That's sort of a natural reaction, right? So that little distance and being outside really helps us be able to do more outside without masking, which is a nice break. It's a nice break. I now have an enormous variety of masks, and I try to color code it with everything I wear. For those of you who are fashion conscious, you might enjoy that. But I wear it when I'm inside, and because I'm nervous about this, I'm nervous about this variant, and I have grandchildren that I like to be around, and so I'm very worried about that. So, this vaccine is doing what it's supposed to do. It protects against really serious disease in about 98 to 99% of people. Remember, nothing is absolute. And so there will be breakthroughs, there will be breakthrough hospitalizations. I just looked up the data this morning. And so it was essentially anywhere from the hospitalized patients who've been vaccinated versus the hospitalized patients who are not vaccinated, who have COVID, runs anywhere from 93% unvaccinated to 99% unvaccinated, with the other percentage making up 100% are those who are vaccinated. So clearly, this vaccine is preventing hospitalization. And there have been hospitalizations and there have been deaths because nothing is absolute. And also, sometimes COVID can set off your normal diseases, your cardiovascular diseases, the things that cause heart attacks and strokes. And so there's a variety of ways people might die, but the COVID might be the precipitating event that made that happen. So there are going to be breakthroughs. There is with every single thing we have in medicine. That 95 to 99% effectiveness is unbelievable for a vaccine. So if there are any questions about that part before I get into sort of like the questions I hear about the vaccine, are there any questions about the stuff I just mentioned?
Hi, this is Tammy Meddy. I am nursing faculty, and I just wanted to clarify on one of your statements. You talked about the 6 foot distance. You were saying within that 6 foot distance. So in a lecturing type of environment, if the lecturer is more than that 6 foot distance away from the students, is it a scenario where a mask would not be needed if that instructor was vaccinated or not?
No. So because of the air currents in a classroom and people getting up and moving around and instructors getting up and moving around, I would be totally uncomfortable unmasked. I am a huge proponent of masking indoors, particularly to protect our faculty and particularly to protect our students. As I said, masking is really a great idea. So I believe that that's necessary until we get, I think they've estimated it now, about 80% immunity. So 80% of folks vaccinated, then it will be so hard to find a susceptible host, then we'll be able to take the masks away again. So we do have some sense of that, but no, I would not count on distance alone. I believe that the masks are going to make everybody safer. But that's a great question, so thanks for asking it. So let me get into the vaccine because I have a lot of questions about the vaccine. So, and some of them have to do with, oh my God, they did this so fast. They must have skipped steps. And they didn't. This is almost miraculous as far as I'm concerned, because I've been involved in vaccines my whole life. I was actively seeing patients in the hospital, kids, in the early 90s when the first Haemophilus influenza vaccine started coming into play. And I have to tell you, it totally changed the way, it totally changed our hospital census. We weren't seeing kids coming in and dying anymore. To me, so I experienced this personally. It was like, oh, wow, that can happen. So I know that vaccines can really make a big difference. And we've been working on solutions to this whole issue of mutation and how do we get a vaccine that's going to be good for life. And so people have been working on this for probably 10 to 15 years, and they've been looking at the mRNA as one way to do this. So what this is this is a little piece of RNA, which goes to the ribosomes in a cell and it codes for proteins. So that's all it does. That messenger RNA goes to the ribosomes, it codes a protein, the protein is made in the ribosomes, and then that goes out and goes to the outside of the cell. And so that's how mRNA works. And so the question was, if we genetically program this mRNA to code for different proteins that are the targets for viruses or bacteria or all sorts of things, is that a good way to get those cells so they have a protein on the outside that protects them from getting infected? And so the technology has been worked on for many, many, many years, many questions about like what kinds of targets. They've looked at Ebola, pretty effective with that, and dengue is another one they've looked at. And so they can code the mRNA so that it's specific to make a protein. And that's all it does. It doesn't go anywhere, and it only goes into immune cells because those are the only things that pick up foreign protein. This is not a virus, right? It's just a piece of protein. And so it only goes to the immune cells because those are the cells that pick up protein that's foreign to a person. And once it gets inside the cell, the mRNA then goes to the ribosome and it makes the protein. And so the COVID mRNA vaccines code for the spike protein, and the spike protein is critical for the virus being able to engage and infect cells. So if you have antibody to spike proteins already developed, then the antibody gloms onto the virus, and that virus cannot infect any cells. And so that's sort of the way this works. So the mRNA, it goes in, it codes for a protein, and then it gets destroyed. The mRNA does. That's it. That's all it does. It doesn't go anywhere else. It only gets in the immune cells. It doesn't go into other tissues. It just gets destroyed after it does what it's supposed to do in the cell, the immune cell, to make the spike protein on the coat, and then the antibody system goes crazy. One of the reasons we have side effects to the vaccine, because our immune systems get revved up and they make antibody to that spike protein, and that antibody then is what protects against serious infections because it's there waiting for the virus, and as soon as it sees it, it clombs onto it, makes it inactive, and it goes away. So it's an amazing technology, and the fact that they had already genetically coded the SARS-CoV-2 virus back in December of 2019 made it very easy then to take that genetic code for the spike protein and put it into an mRNA particle. So that's what went fast. The mRNA technology of vaccine had been worked on for years, but knowing the genome sequence, being able to make a special mRNA, that was what was able to be worked on very fast. In addition, I think you all recognize that, we were all scared. Everybody in the world was susceptible to this virus. And so scientists got diverted from their usual work and they got to work on COVID too. So there were a lot more labs, a lot more money, a lot more time, a lot more scientific expertise that came together to be able to really generate these mRNA vaccines. Then, before anything can ever be authorized for use in humans, it has to undergo testing. And there's a lot of testing it has to undergo. We don't have a good animal model for this disease yet. So they started in really small trials and all they're looking for is safety. So they started in like 10, 15 people, different doses, and see how they did with the safety profile. So it's always safety first in when starting to do the clinical trials. And then they expand it when they find the right dose and they find a good safety profile. Then they have more people and they look at it even more intently for the safety. But to show effectiveness, you have to have tens of thousands of people in a clinical trial. And that's what the companies did. There's over 60 to 70,000 people who enrolled in these trials. And they were done exactly right. They had a placebo group and they had a vaccine group, because that's the only way you can compare the effectiveness and the side effects of a vaccine. You have to have a placebo and you have to have the active component. And that's what they did. And from those tens of thousands of participants in the clinical trials, they were able to show the effectiveness was close to 95 to 96%, which is like one of the highest ever. And they were able to show an enormously safe profile. So we know that this vaccine turns on the immune system. So you can get a fever, you definitely get a sore arm. I got a sore arm. It wasn't bad. Some people get a lot more than that because the immune system's really revved up. I always like to think about that as like, okay, this vaccine really took. I mean, I had a good response. Now I have lots of antibody. And that's what it does. So the side effects are manageable. Couple days, some people longer, but for the most part, the vast majority of people got sore arms and maybe felt off for a day. That's it. That's a very, very safe vaccine. So the safety profile was excellent. The effectiveness was far more than anybody thought we were going to be able to do, far more. And so the FDA looked at every single piece of evidence, all the clinical work that had been done, the clinical trials. They have investigators that go through the data to make sure every single piece has been validated. Like there is a paper record, or in this case, a computer record, of how each of those cases went. And then they look at the statistics and they confirm that the statistics that were done by the investigators was correct. So it gets checked, double checked, triple checked, because that's just the way the FDA works with vaccines. There were no shortcuts. We were lucky, really, really lucky that the technology had moved forward fast enough that we could respond. I mean, again, I think this is sort of miraculous again to be able to do this so fast. But the emergency authorization, all that means is you don't have 2 years of follow-up data yet, but it is safe and effective, period. And so what are they doing now? Of course, they're keeping all the records. And they're doing all the follow-up data in real time. So now that has been presented to the FDA and it's expected to be fully approved within the next month, because they have follow-up data now that's really important, right? But that's the only reason it was an emergency authorization. There would have been no authorization if those big clinical trials had not shown this vaccine to be safe and to be effective. So it's extraordinarily impressive. I didn't know our stodgy scientific community could actually move that fast, ever. And so it was remarkable to see how people really made this work. So that's what the mRNA vaccine, it doesn't get into DNA, it doesn't get into other cells other than the immune system. So therefore, the side effect profile is really about the immune response. And so, questions like, can this affect fertility? No. Can affect a pregnancy? No. COVID can, however. Women who are pregnant who get various infectious diseases actually do poorly because their immune systems are somewhat suppressed during pregnancy to allow the pregnancy to continue. And so COVID itself can cause a lot more problems in pregnancy, but this vaccine does not do anything for pregnancy. It just simply doesn't do that. I looked up, because I'm asked frequently, well, people die because of this vaccine. So I looked this up. As of today, there is a national reporting system called VAERS, the Vaccine Adverse Events Reporting System. It is run by the CDC, and the way it works is anybody, a healthcare professional, a person who gets a vaccine, they can make a report online about anything that happened to them after the vaccine. And so that's one way to really to try to identify rare side effects that might occur, because we already know the common side effects because of the clinical trials. They were so large. So I looked it up today. In VAERS, just to put this in perspective, this is from December of 2020 to August 16th of 21. In the VAERS system, which is non-scientific, all it is people just report, right? It's not scientific at all. But there were 6,789 deaths that were recorded after a COVID vaccine. That was out of greater than 357 million doses. That's how many doses have been given out. Greater than 357 million doses. So that works out to 0.0019%. And interestingly, these deaths are from all causes. So it did not discriminate at all in the VAERS system as to what was it that caused the death. Was it a heart attack, a stroke? Was it some other event? Did they die in an automobile accident? So what happens is the CDC then starts investigating things to try to really nail down, is there anything that can be linked? And so far, the only thing that has been somewhat linked to a death directly from the vaccine is the thrombosis that can occur, the thrombosis with low platelets, which is exceedingly rare as well. But that's the only one that really makes any sense in terms of its effect from the vaccine. So that's an incredibly safe vaccine. The other thing I looked at was the myocarditis, because that actually is seen in males more than females and in those under 30 years of age. So some of our student athletes, for example, have had high profile cases. In the VAERS system, there are 1,306 cases, again, out of greater than 357 million doses. And they've investigated all of those. And they tend to be mild and short-lived. And because they're under 30 and generally are healthy, they get over it, which is really, really good. But those were investigated very, very thoroughly, because that was one of those things that had been identified. So truly, there's some deaths that happen after COVID vaccine, but they have not really been linked to the vaccine itself. And so I think that's really important, and because it's so rare. So side effects, rare. Anaphylaxis is the most common one, and we've known about that. That's a concern for every single vaccine and for every single medication and for almost every single food and anything, really. Anaphylaxis is a massive and difficult, severe allergic response where you can't breathe, basically. So it's a medical emergency. So we knew those were going to happen. And so there have been about 2 to 3 million cases of anaphylaxis, again, out of greater than 357 million doses that have been given. And I really want to put that into perspective, because I think people read like, well, somebody died of the vaccine. And that's not a good way to consider this. They might have died for a variety of reasons after they got the vaccine, but it's one person. So it's really important to put this into the context of how many people actually already been vaccinated, and what do our systems for following up, because this is the most highly followed vaccine ever in our history, because it was new. We wanted to make sure everything was right, and it is. But no shortcuts in doing this vaccine, none whatsoever. And it does not affect other organs, and it's very effective. So again, I will pause for questions. I'd be happy to answer anything.
Dr. Larson, this is Joyce.
Oh, go ahead, Joyce.
Can I ask you also about what do we do to protect our children and those little children like our grandchildren who can't yet get the vaccine?
Right. You know, and I think the other thing that's very impressive is that, you know, currently they've got the vaccines trials going on in children, and they've already developed what dose is really good. It changes from age groups, the youngest one. So they're testing it in 6 months and up. And they've already got the dosages already determined for the safety profiles that make great antibody. So they're rapidly working on the vaccines for our kids, because I totally agree with you. This Delta variant is not, I mean, it is hitting the kids. I was just reading a 15% increase in, I should say, there were 15% of all cases recorded last week were in children. That's terrifying to me. So what we can do is, as a grandparent, I got vaccinated as soon as I could, and then I wear a mask for now. But we do have a pod. So the pod system still works. You know, we all got used to our pods of people that we were all careful, but when we got together, we didn't have to be careful because everybody was careful. So that's another way. The pod system works really, really well. But my kids are all vaccinated. And so it's really the grandkids we really pay attention to. And when they go out, they wear masks. When we have our small family gatherings, it's just our pod. But we have to be really careful again, because now they're at risk. And it's also, I think, very important. The American Academy of Pediatrics has recommended that kids in school wear masks for the exact same reason. Remember, masks protect from air going out and air coming in. And so the teachers and the students in the classroom with those masks on, I mean, we really had to get back to in-person teaching because of the need for that social interaction. And really, there was such a variability of opportunities for kids to learn. So I think the masks are going to be really important until we get the vaccine, but they are working on the vaccine really fast. And I've seen dates, October, November, for an emergency authorization for the kids to be vaccinated, which will be ideal. That's one we really want. But we have to be very, very careful of our children and our grandchildren.
Dr. Larson, this is Stacy Crouch. I'm a nursing instructor in Winnemucca. So I had a question on the sort of the nothing against the children, because I have grandkids too and grown kids. But what about those of us that experienced anaphylaxis? I mean, I cannot find I'm having a hard time finding some data or information, because I experienced it from the first vaccine. So they refused to give it to me again, which correct. I don't want to feel like that again. It's horrible.
Was it one of the mRNA vaccines?
It was the Mrna.
Okay.
Yeah. So, I mean, so here I am, I'm, you know, nursing. So all of that plus that, and I can't find, I mean, I get calls from the CDC. Where do I go? And I have other people I know that have had similar issues or something like this. Where can I direct them to?
So if you got one with the mRNA vaccine, you can get the J&J.
No, that's good to know. Because then I can tell my lady.
J&J vaccine, and they have they're different vaccines. So you can get the J&J. There was recently an article published in JAMA that looked at second doses after anaphylaxis, and the vast majority of the folks did not have an anaphylaxis with the second dose. So they actually did a study in JAMA. You can look it up if you'd like to. So it's about a second dose of the mRNA vaccine after anaphylaxis.
Thank you.
Okay, and the other thing is, for the definition of anaphylaxis, it's really you had to have epinephrine. If you had another kind of allergic reaction, that's not anaphylaxis. There were lots of those with the skin rashes, that's not anaphylaxis. Only the threatened breathing is anaphylaxis. So if you required epinephrine, it was truly anaphylaxis. So that's another
Correct.
way to
I
help.
have it at my house.
Okay, you got it then. But the J&J is fine.
Oops. We lost you, Dr. Larson.
I would encourage you to read that. I think it would be very concerning.
You're back.
Can I just make a comment? I don't have a question, Dr. Larson, but I'm grateful for a very succinct and really excellent summation of the science behind this. But also, I think as Americans, we all forget the global forces behind all this research. And it really is a stellar example of the good stuff that globalization can bring when you have the whole world hitting this thing hard. And you pointed out the researchers who've been doing other things just went bam, they're straight onto it. And we forget that when we think about, well, is it safe? Is it da 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 da? And you're looking at, how many people were involved. And then there's people who weren't directly involved, who are the critiques of those things like you are. You're looking at those journal articles, you're looking at those studies, and you're analyzing that. And so we have all those checks and balances from researchers who are doing the stuff that they should do for the scientific process. But, that's something that we don't look at in our own society very well, but it's awesome to hear it. So thanks.
Well, we should be very proud.
Yes.
I also just have a quick statement. I just wanted to thank you for sharing this information with us. I think this format has been especially helpful. And I think this format would also be helpful for sharing information with our students as well. I know that I've learned a lot, and just being able to have an open-ended forum to ask questions has been very helpful. So thank you.
I have a quick question. So I know a few people who got COVID who don't want to get vaccinated because I'm just wondering about what, I don't know enough to know anything to say to anybody who's had it and thinks that they're now immune, or should they get vaccinated and why, I guess.
Wonderful. I had forgotten to touch on that. So here's the latest on if you've had COVID, should you get vaccinated? The answer is a rousing yes. And here's the reasons why. First of all, if you got the first kind of COVID, the immunity that was developed to that specific strain is not as robust against the Delta virus. And so people who've had COVID from the first strain, got infected with the Delta, are actually a lot sicker. And so what the vaccines do is they have a much more generic pattern to their protein, and so are able to be much more effective than actually than having the COVID. So the answer is yes, they definitely should get vaccinated, and it will really improve their immunity and their ability to not get reinfected. I mean, I hate to sound the alarm, but if we don't reduce the number of susceptible people in our populations, we will keep having variants develop, because that's how they develop. When people are infected, that's when their RNA begins to mutate and such. And so until we have enough people with immunity, good immunity, then we are going to continue to see variants develop. And that scares the heck out of me. And so right now, our vaccines protect against the Delta variant quite well, very, very well. And so this is the optimal time to get this vaccine and to really reduce the number of susceptible people. And so people who are not vaccinated are susceptible. Essentially, that's a better way to think about it. And so we really want to really move our susceptible people a lot farther down so that there's not so many of them around, and particularly because we can't vaccinate our children yet. Once we can do the children's vaccinations, then our percentages are going to go up pretty fast because they're a sizable percentage of our population. So that's going to be another real critical piece. So in the interim, again, for schools, the masks are really, really a good idea. They're very effective. So thanks for that question, because I think that people think, oh, I'm going to be protected now. No. They may get a more robust side effect from the vaccine, but they need better protection than their natural immunity this time.
Dr. Larson, I also had a quick question. Hi, my name's Morgan. I'm with the communications department here. I really appreciate your time. It's been very informative, so I appreciate it. I was just gonna see really quick. I know you had mentioned, if you can go more in depth with it, but I know you mentioned that vaccinated and unvaccinated both carry the virus equally.
Yeah.
And I'm not sure if, yeah, so if you can go more in depth with that, that would be fantastic. And then if so, in your opinion, what would be the reasoning behind the mandatory unvaccinated COVID testing and not also testing the vaccinated?
Okay, those are really good questions. So what was determined in the first strain that came out, that the vaccine actually protected against reinfection and transmission. So that when you had the old strain and the vaccine, you did not transmit. All right, so this is all about the Delta variant, which is greater than 80% of our cases now, right? And so it can reinfect, and you can have virus in your respiratory secretions when you get infected. And so it appears not to be as much. So it appears not to be as much, but until there's better data about exactly how much is there and how transmissible it is, I like to be more cautious about the mask issue. But it appears that actually those who are vaccinated have less virus around. So they're not going to be transmitting to the same degree as an unvaccinated person who has very high levels, particularly of the Delta variant, because it's 2.5 times more transmissible because there's so much more virus that is manifest. So the whole mask thing is an intermediate step just to reduce all risks, and the likelihood of having, the likelihood of getting reinfected is pretty low once you're vaccinated. So it's not a big number at all. And so that's not going to be very common. So testing them routinely would not make any sense whatsoever. So the wearing of the mask and testing of those unvaccinated will clearly uncover people who are not only infected, but infectious. And that's really important for them to know, for their family members and for everybody else around them to know. But it would be sort of a low yield to test those who are already vaccinated, because the data is trending to much lower virus levels. And so potentially below the level where it's very transmissible. But that still needs to be confirmed. But those are the trends that are starting to come out in the literature. So that's why I hedged a bit. I would love to tell you, you don't have to worry. But I think we just need to be more careful. And that's why the mask mandates right now are so very, very important to be able to do that. So I hope that answered your question. Okay, and it's all about the amount of virus, by the way. As it is with everything, it's an inoculum. So the bigger the amount of virus that you're exposed to, the more likely you are to get infected. And so if it's a very low dose of virus that's around, you're less likely to transmit. So that's why those things are really important, and why they're beginning to measure that, so that they can give a better definitive answer to, so do vax people really need to not worry? Not yet, not yet. But we'll find out pretty soon, I think. And I saw in the chat box here about boosters. So I am not surprised. We sort of thought we might, because this coronavirus mutates, that we may have to alter the vaccine, just like, influenza, we have a new vaccine every year to be able to address the mutational changes in the influenza virus. And that's just the way it is. And what might happen with COVID-19, where it becomes that kind of a virus, just like influenza is, where there's sort of minor changes and we tweak the vaccine each year, and we have to have a vaccine each year. We don't know yet. We don't know yet. But what is increasingly concerning is that this Delta variant is causing reinfections now. And one of the questions is is the immunity waning? And if the immunity is going down, it's going to go down in those who are older, because their immune systems are not as robust. It's going to go down in those who are immunocompromised, which includes those who have cancer, who are doing chemotherapy, who are taking steroids regularly. All those folks don't mount the same response either. So you saw already the FDA recommends boosters for all those who are immunocompromised to boost up their antibody levels to make sure that they're high enough. And now with the more routine adult boosters being recommended for September, it's the same kind of thing. Let's, before winter, and we all go in again, let's boost people's antibodies with a booster dose. So I'm very interested in getting my booster dose. I really miss travel. I think probably lots of people miss travel a lot. And so, and now that I'm retired, that's actually what I'd like to do is travel. So, so I intend to get my booster and rev up my antibodies so that I feel a little bit more secure about travel. And so I think it's a good idea. I know it's a very interesting philosophical and ethical questions that come up about why should we get boosters when the world hasn't even had their first dose yet. And that's not for me to answer. I think it's something that we need to think about. But the boosters do have a basis in science. And it wasn't a surprise because of this virus and what it does.
Any other questions for Dr. Larson?
Let me see if I missed any on here. Okay. I didn't see any in the chat box either that I could address. Anything else I can?
Dr. Larson, your explanations, I mean, your expertise, it's so welcome, and we're all very thankful. I think also your easy way of explaining it to us, those of us who are not have a background, who don't have a background in science, very welcome as well. So last chance here for anyone, and again, all questions are okay.
Absolutely.
Any last thing burning? Thank you so very much. We've recorded this. We're going to be sharing it. If someone didn't make it, we're also going to share it with the school district.
Well, excellent. I really enjoyed this. Thank you very much for inviting me. I sort of miss being in front of a class. I did that for so many years and really, really enjoyed it. So I don't think of you as a class, but
we are.
Are my colleagues, and so it's delightful to be able to be invited in and to answer questions, and I'm very happy to do it.
Well, Dr. Larson, I have a feeling that Chantel, who works with our students, probably was going to tap you on the shoulder too, because I know she was saying, oh, the students need to hear this. So we're not, you probably won't get away from this without that. Thank you again.
I can.
And happy retirement. Thank you so much.
Thank you.
Bye-bye.
Bye.